Hold on 1 second. Okay. Welcome, everybody. I would like to welcome everyone to our 5th installment of the Back to School Lecture Series. We know that the school year has begun for all students by now, which means that parents and caregivers alike are back to supporting their children along their educational journeys. It is a collaborative effort for students with special needs, and today we are getting to the heart of what parents really need to know as it pertains to physical therapy in schools. We are so thrilled to have our very own Dr. Nia Mensah with us today to discuss physical therapy as it relates to the special education realm. Dr. Nia Mensah is a board-certified specialist in pediatric physical therapy. She is also the founder and president of Kasudi International Incorporated, our Back to School Lecture Series co-sponsoring organization. Dr. Mensah received her PhD in kinesiology from Teachers College, Columbia University, and her doctorate of physical therapy degree from the University of Southern California. Dr. Mensah and I met almost 15 years ago, working together in a pediatric rehab setting. She is a strong and passionate advocate for children with disabilities, and I'm so happy our paths crossed so early in my career. Parents and professionals that have joined us today, please do not hesitate to ask any questions that you may have during Dr. Mensah's presentation. I will monitor the chat room for questions for the first half hour, and at approximately 12 o'clock, we will be providing Spanish translation of today's presentation. So, without further ado, we welcome Dr. Nia Mensah. Just making sure I didn't freeze. Dr. Mensah?
Good morning, everyone. Thank you. Sorry, I had a little technical difficulties. I'm back.
Okay.
To sharing today. Thank you, Candace, for that wonderful introduction. I just want to give a quick shout out to DeQueen. She is our collaborator representing the Autism Project Floss. I know she's connecting to audio, so I did want to give her a chance to say hello, but if not right now, we'll definitely do so in a moment. Let me go ahead and start sharing my screen. Thank you for those that are joining us. So I'm going to give a brief overview about pediatric physical therapy, specific to some of the things you all need to know is from a parent's perspective. I am a board certified specialist in physical therapy, and I am founder and president of Kasudi International. And the slides that I'm going to share with you today, I have to give credit to some contributions from the American Academy of Pediatric Physical Therapy. So first, I'm going to talk about what pediatric physical therapists and pediatric physical therapy assistants, who they are. They are highly educated and clinically trained professionals that typically work with individuals from birth to adulthood that are affected by movement dysfunction. These individuals typically have a strong desire and a unique talent for working with children, meaning we know how to get on the floor and play and get down to our children's level and enjoy actually engaging them, getting them motivated to play. The goal of pediatric physical therapists is to help children reach their maximal functional level of independence. And this is important because that is varied and very individualized. So we do focus on trying to meet a child where they are, whether they're non-ambulatory or non-verbal. We work with the team to see how we can help support with equipment, interventions, hands-on, and motor learning principles so that these children are able to engage. When looking at pediatric physical therapy, some of the interventions specifically focus, again, on improving independence so that child can engage and participate with their classmates, their family, and their community. We hope to facilitate motor development. If you're working as in the early intervention, which is from 0 to 3 years old, our focus will be working in the home and helping the parents and the caregivers to facilitate motor development, developing a motor skills and function. We can also improve strength using resistance training or endurance training, and we want to help improve learning opportunities. So we're focused on back to school. This is our back to school lecture series. So we work with the academic department all the time. We want to know what the child is learning in their day-to-day, whether it's colors and letters. We may want to work with the vision educator to improve their ability to locate glitter or shiny objects so that we can help foster that development and learning opportunity. And another thing we really do try to do is ease the burden of caregiving. That usually is synonymous with helping with equipment, equipment assessment, or writing of letters of medical necessity, so that the parent, if they are in need of a Hoyer lift in the home, or if they're in need of adaptive seating devices, orthotics, we try to come alongside to help teach the parent and come alongside and support them in whatever their goals are, so that they can go about their day and do the things they need to do to care for their child or other children. And we also promote health and wellness. So in the pediatrics section, we're really attempting to promote lifelong physical therapy consults. So we work with children from birth throughout into adulthood. So having a physical therapist that is someone that you have for the family, like you would have a pediatrician or a dentist, is very important, because a child with special needs will have different needs during their lifespan at different phases of their life. So that's something that we will encourage, and there's different ways we do that to promote health and wellness. I talked about participation, super key. We as physical therapists want to help increase children with special needs engagement in their home, school, and community. I'll talk about the laws in a moment, and you got a little bit of an introduction in special ed, as well as some of the other therapy lectures, but we really strive to allow children that do have a disability not to be excluded in their everyday. We want to engage them. We want to help them participate in daily activities, whether it's the use of augmentative and assistive communication devices, or if it's going to be allowing them with walkers to engage or enter into a classroom or stand around a desk, or the use of a stander so that they can be upright if they're not able to stand on their own. As you all know, the purpose of this series is to come alongside and support the parents in any way we can. Parents and families are the primary participant in the child's development. We do not, as pediatric physical therapists, subscribe to the idea that what we suggest is the best way. We like to know where the parent would like us to come in and understand the family goals. It is critical for a pediatric physical therapist and a physical therapy assistant to collaborate with the family to develop an individualized program for each child. There are various cultures, there are various interests of every family, and we want to make sure that we are assisting in any way we can that meets their needs. Okay, so there's different ways we support the family. We can help coordinate services. This may mean actual physical therapy intervention, whether it's a mandate on their IEP, or they're getting medical physical therapy in the home, in the home or in the doctor's office or in a hospital. We also help to advocate. If you are a pediatric therapist in general, you understand the importance of advocating for children and families that may not understand the laws or may not understand the process of the IEP system. So we advocate for either for more services or more education, or just giving parents resources that may be beneficial to community engagement. And then we also, again, assist with enhancing development, and that specifically happens with collaboration. So the way we enhance development in terms of collaboration, we work on 4 key areas. Number 1, positioning during daily activities and routines. Now, this is critical. I get on my soapbox about this one when I teach my students at LIU, because as a PT, you're only going to have access to the child that you're treating maybe 2 times a week, maybe 3 times a week. If you're lucky, 5 times a week, but that's not typically the case. And even if you do, you don't have them for the entire day. You see them for 30 minutes to 45, maybe an hour a day, and the rest of the time, your child is in a seating equipment in the classroom. If they are non-ambulatory, they're in a wheelchair. And it's super important that we focus on alignment and making sure our children are comfortable and in optimal alignment for development, engagement, and participation with their teacher and their peers. So that includes making sure that there are seating devices that put them at eye level with other peers in the classroom. A physical therapist will help with that. Or if they are not able to stand on their own, providing a standing frame with the collaboration of the teacher to understand when there are opportunities where we want them to be more upright, and having them have position changes is super important. If the child is ambulatory, we may be concerned about making sure they have support, supportive tools, just like the OT mentioned, whether it's adaptive spoons, whether it's adaptive pencils, to help them engage. And that will also go along with having a tray on their chair or sitting at the appropriate height in the classroom. We also do something called adapting toys for play. And this may have been talked about with Ms. Hunter. We adjust adaptive toys. If they are unable to reach, we may use a switch or something to have that child be able to indicate a cause so that they can play with an effect. You may hear this in terms of cause and effect. Very important, and this is a skill that you typically see about the age of 7 months. So a child is understanding that if they do one thing, something else will happen. And so we want to encourage children to be able to engage in play. That's what children's roles are in society. When they get to school, it's play and learn. And it is it's very imperative that a physical therapist understands that and collaborates with their OT and their speech therapist to make sure that we're getting the appropriate toys related to their cognitive and social skill level. And I talked a bit about positioning and using adaptive toys, but that speaks to now moving into expanding mobility options. So this would include use of a walker, use of a power wheelchair, or a manual wheelchair. We do assessments with the team. You don't always see this in the school unless you're in a very specialized private school where they may have an equipment clinic. Typically, this is done through your physiatrist or your pediatrician and or physical therapists from the team. And they would collaborate to see what are the best needs so that that child can be as, again, independent and functionally engaged in the classroom and at home. And then we use equipment effectively. We'll collaborate, we'll train the people in the school, we'll train the paraprofessional, the teacher, so that the child is properly using any orthotic, any seating or standing equipment, any gait trainer, so that they're getting positional changes or they're participating in obstacle courses safely and navigating their school environment without falls or hazards. So other ways we can help support the family is that we educate based on what the goals are of the family. I must admit, this series has been so informative in terms of the parent feedback. We want to know how we can better serve you. So I can teach you a little bit about physical therapy, but we learn so much from the interests of the parents so that we can help optimally improve that child's engagement at home and at school. So we collaborate. I don't want to say it is PT educating the family, more so it is a collaboration and a sharing of ideas and concepts between the family, between the teaching staff, between all of the therapists. And we work together to figure out how we can help and learn from each other to optimally affect and improve the child's engagement at school. We can provide information. So physical therapists can conduct an evaluation. I'll talk about how that happens in the school system. However, we can give you information about the level of the child's strength, range of motion, which is the mobility of an arm, for example. How far can this arm extend? We can give you a value of that. We also give information about their endurance level, how long a child can sit at the edge of a mat, or how long is a distance can a child walk before losing their balance, or how active is that child in terms of understanding a 1 or 2 level command. So those are things we can give in terms of information to the team and to anyone that is working with that individual. And then we also assist the child and family from training from early childhood to school and into adult life. By the age of 16, there will be a transition plan on the IEP so that we are already thinking of how we can support the family and the child as they transition towards the end of their academic career. All right, so if you need to, or you have a concern about your child as it relates to mobility, first, if you're in New York and the child is under 3, you can call 311 right now. You can ask for a pediatric application for early intervention, and then you can get you will get a caseworker and fill out an application as it relates to what are your concerns. After that is established, usually an evaluator will come to the home to conduct a physical therapy OT speech evaluation. And once that is done, you will get a standardized score based on where that child is performing. Now, in the school system, it's a little different. If you have concerns and they have not already been seen in early intervention, you have to write a sample letter to the school representative or the case worker for yourself or a social worker, and CC the principal. And there are sample letters, I will share that in a moment, on how you can request physical therapy services or an evaluation for your child. Once the evaluation is conducted, and I do want to encourage parents to ask about what scale is used when a child is being evaluated in physical therapy. It's very important because sometimes, because of the complex needs of a child, they may not use a standardized exam. It does happen. However, it is important to qualify for services and the amount of services when you have an age equivalent, meaning a child is performing at a certain age level that may be younger than the age of the biological age of your child, right? The chronological age of your child. So it's important to understand what type of evaluation is being done, what is the outcome before you go ahead into that IEP meeting, or if it's a preschool to CPSE meeting. And so you understand what has been done with your child and what the outcomes are, or at least the clinical opinion of the therapist that did the evaluation. Now, when a physical therapy evaluation is done, I kind of talked a brief about standardized exams, but we may do assessments of functional strength and mobility, use range of motion assessments, use something called a goniometer to measure what the range of motion is of different joints, depending on the child's level of functioning. We also look at muscle tone, which is considered the tightness or the stiffness of a muscle. Now, this is really important because most families don't understand or learn about tone until the child is a little bit older. But if you have a child in early intervention between the ages of 0 and 3, and you're feeling like their muscles are a little tight or even flaccid or floppy, it's important to make sure that you bring that up to your pediatrician, because there is imaging that can be done, whether it's an MRI or standardized testing that can be done to determine if your child may have a neuromuscular disorder, something like cerebral palsy or Down syndrome. Usually Down syndrome is diagnosed a lot earlier, but maybe another genetic disorder. And so it's important to inquire about anything that you're noticing that you don't feel is typical in your child. So we do assess this. We do this by looking at muscle, joint function. We look at strength and endurance. So it's really hard to have a manual muscle test, which is something you may do in an outpatient clinic, to have a child say, okay, push against me. Some children don't understand one-step commands. So usually when we look at strength, we're looking at functional strength. Are they able to pick up a set of blocks? Are they able to reach above their head? And that's how we would document their progress. Cardiopulmonary status looks at the child's ability to engage in activity. Heart rate may go up, which is normal during engagement in physical activity, but ideally it should come down after a few minutes. So we can look at that, see their level of fitness. A child that is active or may have autism and is nonverbal, we can work on improving their fitness level so that they are able to endure a full day of school without having excessive slouching or without having shortness of breath if they're walking from one classroom to the next. All of that can be trained. We look at posture. Again, I talked briefly about alignment when we're deciding on the best type of equipment for a child, and balance. That's when you want to work on someone's ability to prevent themselves from falling over. I know speech went into detail about oral motor skills and feedings, but there are physical therapists that are feeding therapists, meaning we want to understand what the child is able to do in the tongue movement, the ability to close their mouth, because it's super functional in head control. So we look at head and posture and balance, but if a child has a difficulty closing their mouth, that is absolutely going to affect their ability to bring their chin down, have their head over their trunk. So these are things that physical therapists can also assess. And the OT talked a lot about sensory integration and how we look at that. So as a physical therapist, we work alongside with them to address any concerns that we might see as it relates to their ability to tolerate different textures and engage in different environments as it relates to the senses. And then we definitely talk about use of assistive technology, which is any adaptive piece of equipment that will help a child engage in their school environment. So pediatric physical therapy, again, collaboration and coaching. Coaching includes mentoring or encouraging an individual through education. And that's something that we can do that has nothing to do with hands-on. You can coach someone without doing actual intervention. And so that's something that we're moving into when I talk about promotion of health and wellness. And then we really emphasize the importance of the natural environment. Children learn best when they're in their natural learning environment. That is the home, that is childcare centers and school, of course. And if a child is working as a teenager, we can also work in the job site. There are physical therapists that spend the majority of their time doing work evaluations or looking at the environment and helping that so that individuals that work for certain employers are sitting with optimal posture and making sure that they are not doing anything that will cause overuse injuries that could potentially lead to surgeries. And I know we're not focusing on hospitals, but it's important to know that physical therapy in the hospital is specific to acute care episodes or any related medical conditions, cancer, post-surgical intervention, any kind of anoxic brain injury. They will get physical therapy in the hospital. Typically, if it's something that happened after a motor vehicle accident, at a higher frequency than you will see in the school setting, because we do know if there was some level of brain injury, intense rehabilitation has been shown to show rapid changes to the brain in the first year, specifically after some level of brain injury. So you may see increased intensity of physical therapy related to medical physical therapy services. All right. Now, how do we determine if your child is eligible? I talked about early intervention, but let's focus on special education and related services. You are entitled to receive pediatric physical therapy through the Individuals and Disabilities Education Act. It is federal law, Public Law 105-17. And this is super important because there are different classifications or parts in the IDA that allow for a free and available education for every individual. And the environment needs to be least restrictive for children with disabilities. So there was a period where children with disabilities were institutionalized. We have done away with that. We're really encouraging children to be in the appropriate environment with their peers. And this is what the IDEA was all about. There is also another law called the Rehabilitation Act, which is Section 504. So if your child is a victim of a car accident or has had a broken leg due to sports, there are special therapy services that can fall under that umbrella of intervention. So usually if you have a Section 504 PT program, it's usually related to reasonable accommodations under something that is maybe acute or under a special category of disability. So this is an option for individuals in lieu of an IEP. They would have an IEP, excuse me, but they would have a different set of meetings and services as it relates to this section. So that is another thing that you can look up and see if your child qualifies for these services under the Rehabilitation Act. And then there's Americans with Disability Act that protects the right of all individuals with disability. All right, so school-based services can occur preschool, elementary, middle school, and high school. And there are 13 different disability categories under which ages 3 through 21 years may be eligible for services. Most parents are not necessarily aware of the fact that your child will be classified if they have an IEP under one of these 13 categories. The 13 categories include autism, deafblindness, deafness, emotional disturbance, hearing impairment, intellectual disability, multiple disabilities, orthopedic impairment, other health impairment, specific learning disability, speech and language impairment, traumatic brain injury, visual impairment, including blindness. It is really important to understand that the amount, frequency of services, and the size of the classroom in many states correlates to the classification of the child based on their disability. Let me put it like this. If your child has cortical visual impairment, autism, and cerebral palsy, it's important, depending on the needs of the child, to identify with the best classification out of these 13 that will get them the services that allow them to be maybe a smaller classroom. Most children with autism will be in a classroom with 6 students, 1 teacher, and every child will have a one-to-one. That is very important for children that are nonverbal, who need one-on-one attention as it relates to behaviors, or just to be able to engage with the children in the classroom. What I've seen also, though, children with multiple disabilities may have cerebral palsy, they may have seizure disorders, which cause recurrent changes in the brain that can also affect their ability to engage in the classroom. They may not eat on their own. They may also require assistance using the restroom or being changed throughout the day. They may be classified in multiple disabilities, where in New York, typically you'll see children with that classification in a classroom with 12 students, 1 teacher, and 4 paraprofessionals in the classroom. Well, what if that child needs more one-on-one attention because of their seizures, because of their inability to communicate and let you know when they're uncomfortable? Well, then you may need to talk to your IEP team and discuss other classifications that will allow for more engagement, or even putting them in a smaller classroom so that they can get the attention they need. This is important in terms of advocacy for parents to know their rights. So find out, if you're not sure, what your child's classification level is. And if there is a concern about the classroom size, please bring that up. We'll have advocacy talking to you in a few weeks as it relates to the back to school series.
No. Can I just interject and just reiterate and emphasize how important it really is? The classification, parents, is what drives the services that your child receives. Sometimes you can, feel a little bit guarded or afraid to have your child classified a specific way. But again, it's the classification that's going to drive the classroom placement for your child and the related services that your child receives in school.
Thank you so much, Candace. We can't explain or encourage you all enough, because it's super important and it's not easy to change the classification level. It can be done, I will say that, but it's important to understand that this is one of the most important features of an IEP, or in terms of what your child will receive as they continue with school services. One thing I want to talk about as regards to note that under the IDA, a child that may have English as their second language would not be considered a disability. And that's important to know, because services should be provided in the native tongue of the child. Another thing to think about and understand, and it's very clear, if a child has a deficiency as it relates to instruction in math or reading and science, that they will not consider that a disability. But you can have your child evaluated regarding education, regarding the concern of dyslexia. That is considered a disability. So you do have to make sure you understand, okay, well, they may say, well, maybe they're at a 4th grade reading level. This is not a disability. Well, maybe your child is taking in letters in reverse. Maybe there is a visual issue challenging the child, and that's why they're not progressing. It's important to get a neuropsych eval and an academic eval if, as a parent, you are concerned about a child's ability to learn in the classroom. And if it's just instruction, they will there is a law that says that, well, that does not count as a disability. So I do want to make sure you understand that if there is evaluation done, you can get standardized values of where your child is performing. And at the very least, you can see if it changes year to year. Now, I do want to share this resource. I'm trying to move quickly because I know we're on our lunch hour. So I want you all to be aware of the National Dissemination Center for Children with Disabilities resource. Their website is nichcy.org/state-organization-search-by-state. You can find parent training information for each state and resources as it relates to how you can get assistance to get your child evaluated, or even to come alongside you as you go through the IEP process. So please, if you have questions, there are resources available to you so that you can understand what is offered to you via each state. We talked a lot about individualized education program and special ed, so I'm not going to belabor the point. The YouTube playlist is coming together, so you'll be able to access everybody's lecture. But IEP is developed for a child that is determined to have special needs. There will be an annual meeting. That's where we develop our goals, quarterly assessments. The team, number one, parent. Can't have an IEP meeting without a parent. If you've ever been told we had the IEP and you weren't there, that is against the law. Okay, so make sure that is clear. Parents are required to be in attendance. I've seen some fishy stuff in my years working in the school district. So make sure you know if there was any discussion about goals that the parent needed to be there. And they would need to have another IEP meeting if a parent missed a scheduled one, okay? Teachers should be there. There's a DOE representative and the therapy team members will come in and out. Usually we can't stay the whole time, depending on if it's a busy therapist and they have a whole bunch of kids to see, but definitely will chime in to give a status update on how well the child is doing as it relates to their skills. And the goals of school-based physical therapy is specific to academic enrichment. Now, this is critical. Medical goals should not be on an IEP. Increase range of motion by 15 degrees. Why? If it's not tied to an educational goal, you will see pushback on, well, if that's the goal, they can go to medical PT after school. So if you want to work on a child getting any standard and enduring 30 minutes of standing to improve their cognitive ability, there's tons of research that shows the earlier a child is able to be positioned in a standard if they're not able to stand on their own, at least by a year, that they have more engagement in the classroom, more engagement with their peers, because it puts them on the level of other children that are able to walk, right? So you do need to understand that goals need to be specifically written to help enhance and complement academic goals and complement participation in the classroom. So a goal, physical therapy goal can be increase their ability to ambulate 25 feet in a certain amount of time so they can walk with their peers from one classroom to the cafeteria. Or a child will be able to participate in an obstacle course so they can engage in recess with their peers without losing their balance, right? So there's so many different ways as pediatric PTs, we have to write our goals specific to the environment that we're treating in. But if a child has medical issues, I do want to say this, that may prevent them from participating in everyday attendance, we can address it. The more engagement a child works on cardiovascular strength and endurance, the more healthier they'll be, the more we can reduce school absences. So there are medical reasons they may get pediatric physical therapy in the school. But again, the IEP is clear. You do have to write goals that are related to academic enrichment so that we can see changes that are addressed to school-based goals. I do have to throw this in. I am a researcher. Evidence-based practice, EBP. This is the goal of pediatric physical therapy. We want to integrate research findings, clinical expertise, and value. So we use our opinions and what we've learned and what we've seen work, but we also want to include the evidence, what we've seen to work in research with our children. We collaborate with families and healthcare providers to provide the best practice. And such interventions include developmental activities, motor learning, strengthening, movement and mobility, tone management. I talked a bit about stiffness of a muscle. So it's the response of a muscle to a stretch. If you attempt to stretch a muscle that has increased neurological tone, that tells us there may be something in the circuitry between the brain and the nerves that connect to the spine that go down to the muscle. So if you're seeing a resistance when you try to stretch a muscle, typically that's a sign of spasticity or hypertonia. This can also be assessed by a neurologist, and physical therapists will do clinical measures to see the level of tone, whether it is more of a no resistance, totally no resistance to stretch, that may be a hypotonia, or a low tone, tonal influence muscle. So it's important to understand that there are fluctuations in tone depending on the diagnosis of the child, but we also work in that in collaboration with the physician, physiatrist, and maybe the neurologist. I mentioned motor learning, balance and coordination, recreation, play, and leisure. And we also, again, do interventions that relate to daily activities, equipment design, orthotics. We definitely collaborate with the orthotist and the physician to see and make sure that when a child is growing, that we notice, okay, these are going to get small. We do not want to have blisters. We do not want to have pressure points. So the PT should be on top of making sure or contacting the family when we start to notice areas of redness in the skin, or if their wheelchair is becoming too small, because we know our kids grow, we are the ones that should be on top of that. Burn and wound care by physical therapists is done in the hospital, not in the school setting. And then again, cardiopulmonary endurance, super important to keep our children healthy and to make sure they are heart healthy. And we do safety, prevention programs, and again, use of assistive technology. How do you become a physical therapist? Well, each state has their own laws pertaining to that. Some states have a legal exam in addition to a licensing exam. And so all physical therapists now in the USA have to complete a Doctor of Physical Therapy accreditation series of courses, and the programs are typically 3 years. There are some programs that are now 2.5, but we've moved away from the Masters of Physical Therapy. Now every physical therapist needs to attend an accredited university to get their Doctor of Physical Therapy degree. Physical therapy assistants can acquire an associate degree, and that is a 2-year college program. And they also can assist a physical therapist to do exercise and carry out PT plan of care. Physical therapy assistants do not conduct evaluations, and they have to work under a physical therapist. And their specialty training as it relates to pediatric physical therapy, I did do a certification exam that requires to have at least 2 years minimum of practice in a pediatric setting. And then you take a very long exam and you pass it, you become a specialist. So I do want to share these resources. If anybody would like a copy, I'm happy to share. The National Center on Health, Physical Activity and Disability is a wonderful organization that provides public health practice and resource center for health promotion for all people with disabilities, young to the old, and it's a wonderful, wonderful resource. I highly recommend you checking out that website. And I would be remiss not to share about adaptive sports. Here's some links that you can look and see if they have chapters in your city or in your state, because we want to keep our kids active, regardless of what their special need is. I love to say the children that I work with are amazing individuals wrapped in unique wrapping, right? Or special wrapping, like opening a Christmas gift. They're so amazing. And it's important for us to understand their skills and understand their passion and connect with them. Because once we connect with them and they trust us, you can work with them and they'll have you for the rest of their life. As long as we'll be with them as long as they'll have us, right? So it's important to understand that you want to keep children as active as possible, and there are resources for children with special needs. So I'm happy to share CHOP in Philadelphia. There's some APTA New NY has a resource for children with disabilities right here in the state. So you can see what's on that page. There's some local baseball leagues that are great, and soccer in some areas that you can see where you can find programs for children with disabilities. And of course, equipment. I have to show my little picture of bikes, adaptive tricycling. Now, they're not covered by insurance just yet, but if you collaborate with your physician, you may be able to apply for some foundations and some grants out there to get a bike for the classroom, and it can be shared, or at home if you have the room, right? If you have the space, and you can apply for some funding. You can get an adaptive tricycle for a child with disabilities. I have some computerized speech devices here, or a switch. There's some loan closets in every state, so you can see if you can qualify to borrow some equipment for a certain period of time. Of course, consult with your provider to see what's best, and you want to have carryover. So this is why it's important to have maybe a stander, maybe a gait trainer, so that the child can engage at home as well. That is all I have. Any questions?
The chat room for now is clear, Dr. Mensah.
Awesome. I saw Liliana jump on the line. So this is our contact information. I'm going to turn it over to her because she's going to lead us through what we shared in Espanol. So thank you so much. Liliana is a colleague of mine from Neuro Rehab Lab at Teachers College. And so I'm going to turn it over to our moderator, who's going to introduce you in Espanol. Thank you for joining us.
Yo soy Liliana Romero, soy estudiante del doctorado en el programa de aprendizaje y control motor en la Universidad de Columbia. Hoy yo voy a estar presentando en español la presentación que proveyó la doctora y la terapista física pediátrica Nia Mensah. La voy a presentar en español, para mí es un placer estar con ustedes hoy. Hoy vamos a hablar sobre qué es la terapia física pediátrica y qué los padres necesitan saber. Déjame poner esto en grande. Bueno, para empezar, un terapista físico pediátrico y sus asistentes son profesionales altamente capacitados y clínicamente capacitados. Ellos trabajan con personas desde el nacimiento hasta la edad adulta con difusión del movimiento y tienen un fuerte deseo y talento único para trabajar con niños y familiares. Ahora, ¿cuál es la meta de un terapista físico pediátrico? Pues su meta es poder ayudar a los niños a alcanzar su máximo nivel de funcionamiento de independencia. El propósito principal es lograr que estos niños puedan ser lo más independientes posible y que puedan participar en su ambiente, jugar con sus compañeros, obviamente pues con todos los servicios necesarios. La terapista física pediátrica promueve la independencia, aumenta la participación, facilita el desarrollo y la función motora, mejora la fuerza a través de los ejercicios físicos y del entrenamiento, mejora también las oportunidades de aprendizaje porque pues, los terapistas físicos se ponen de acuerdo y colaboran con los educadores para poder establecer las metas de aprendizaje y pues, para saber más o menos cómo va el niño, si están todavía en el proceso de aprender a leer o si están todavía con los colores y todo eso para poder entonces desarrollar ciertos tipos de metas. También facilita el cuidado porque pues, los terapistas físicos pues, se ponen en contacto con la familia para saber cómo ayudar al niño de la mejor forma posible. Y promueve la salud y el bienestar. Los fisioterapeutas y asistentes pediátricos también promueven una mayor participación en las actividades y rutinas diarias, en los hogares, en las escuelas y en la comunidad. Obviamente para lograr que el niño pues, pueda participar más en las actividades diarias. Y también es importante recalcar que en las escuelas no solamente se enfocan en lo académico, sino que también están bien pendientes al alrededor, al ambiente, por ejemplo, cuánto tiempo de duración se tarda el niño de ir de un lugar a otro, de un salón a otro, cuánto tiempo puede estar sentado en una silla durante la clase. Y siempre pues, están bien pendientes a todos esos detalles pues, para poder asegurar que puedan hacer las actividades de forma segura, ¿no? Ahora, vamos a hablar sobre el crítico rol de la familia. Esto es sumamente importante porque los padres y la familia pues, tienen el rol principal en el desarrollo del niño. ¿Okay? El rol de la familia pues, nos permite poder identificar y priorizar las necesidades de esa familia. Los fisioterapeutas y asistentes pediátricos pues, colaboran con la familia para implementar programas individualizados para cada niño. Ahora, el servicio de apoyo familiar. La familia del niño cuenta con el apoyo de fisioterapeuta y asistente pediátrico a través de coordinación de servicios, abogacía, asistencia para mejorar el desarrollo. Y cuando me refiero con abogacía es que normalmente pues, el terapista físico aboga por los derechos de los niños para que puedan recibir las ayudas que se supone. Y no solamente eso, sino que, por ejemplo, si un niño tiene problemas en comunicarse, pues básicamente el terapista físico pues, es la voz del niño en la escuela. También los fisioterapeutas y asistentes pediátricos pues, ayudan a la familia a mejorar el desarrollo del niño a través de posicionamiento durante las rutinas y actividades diarias, adaptando juguetes para jugar, ampliando las opciones de movilidad, usando los equipos efectivamente. Y obviamente pues, nos enfocamos en que el niño pues, tenga los equipos adaptados según su condición, según la necesidad del niño. Con respecto al apoyo familiar, tenemos que los fisioterapeutas y asistentes pediátricos pues también enseñan a las familias sobre la seguridad en el hogar y la comunidad, proporcionando pues información sobre las necesidades de atención física y de salud del niño. Y también ayudan al niño y a la familia en la transición desde la primera infancia a la escuela y la vida adulta. Ahora, si usted cree que su niño pues, necesita terapia física y ya habló con su pediatra y todo, y el niño ¿verdad? Todavía está en edad escolar, pues, ¿qué debe hacer? ¿Cuál es el inicio del niño en terapia física pediátrica? Pues lo primero es que tiene que pasar por un proceso, una entrevista, ¿verdad? En donde puedan identificar las necesidades del niño y luego realizan una examinación y evaluación del niño en el contexto de sus actividades y rutina diaria. También es importante que ustedes sepan que ustedes pueden llamar al 311 para recibir una evaluación. La evaluación es completamente gratuita. Ahora, la evaluación de terapia física de su niño, pues mide varios tipos de cosas. Una de ellas es que mide la función muscular y articular, mide también la fuerza y resistencia, mide el estado cardiopulmonar, mide la postura y el equilibrio. Cuando hablo de postura me refiero más en que su cabeza y el cuerpo estén ¿verdad? Con una postura correcta, y el equilibrio, cómo hacen pruebas de balance y todo eso, para evaluar el equilibrio. También se mide las habilidades motoras orales y alimentación, como por ejemplo, si el niño cuando come, pues mantiene, ¿verdad? Pues cierra la boca o la mantiene abierta, cómo está su articulación y todos esos tipos de detalles. También mide lo que es el desarrollo sensorial y neuromotor y uso de asistencia tecnológica. Que por definición, pues cuando hablamos de asistencia tecnológica, pues nos referimos a todos estos equipos que son adaptados a la necesidad del niño, como por ejemplo computadoras, las sillas de ruedas y todos esos equipos. Ahora, la terapia física pediátrica también incluye una colaboración y entrenamiento, que ellos trabajan mucho con otros profesionales, y cuando hablo de entrenamiento me refiero a que promueven la educación, ¿verdad? Promueven educar a la familia y al niño para mejorar el dominio y la movilidad del niño. Y todo esto ocurre en entornos naturales de aprendizaje, como por ejemplo en el hogar, en los centros de cuidados infantil, preescolar, en las escuelas y sitios de trabajo. Los niños también pueden recibir fisioterapia pediátrica en hospitales y clínicas cuando reciben atención por afecciones médicas relacionadas o durante episodios de atención aguda. Ahora, ¿cómo saber si su hijo tiene derecho a estos servicios? Pues para empezar, todos los niños desde el nacimiento hasta los 21 años son elegibles para intervención temprana o educación especiales y servicios relacionados. Y tienen derecho también a fisioterapia pediátrica a través de la IDEA, que viene siendo la Ley de Educación para Personas con Discapacidades. Ahora también tenemos lo que es la Ley de Rehabilitación, la sección 504, que requiere la provisión de adaptaciones razonables, incluyendo la terapia física para personas con discapacidad. ¿Qué quiere decir eso? Que si el niño, por ejemplo, no presentó síntomas anteriormente en las etapas anteriores, pero ahora sí está presentando síntomas, entonces puede ser que sea elegible para la sección 504. Y también tenemos lo que es la ley de estadounidenses con discapacidades, que eso pues protege los derechos de todas las personas con discapacidad. También tenemos lo que son los servicios escolares en Estados Unidos, y la educación en los Estados Unidos pues sigue un patrón similar a muchos de los sistemas a la educación de la primera infancia, que le sigue a la escuela primaria, llamada escuela primaria en los Estados Unidos. También tenemos la escuela intermedia, que viene siendo la escuela secundaria, llamada escuela secundaria en los Estados Unidos. Y luego tenemos la educación postsecundaria. Ahora es bien importante mencionar que la IDEA enumera 13 categorías de discapacidad diferentes, bajo las cuales los niños de 3 a 21 años pueden ser elegibles para recibir servicio, ¿ok? Y esto es bien importante que usted sepa en qué clasificación o en qué categoría está clasificado su niño, para poder entonces saber cuáles son los servicios adecuados según esa condición. Y dentro de esas condiciones se encuentra lo que es el autismo, la sordoceguera, la sordera, el disturbio emocional, la discapacidad auditiva, la discapacidad intelectual, las discapacidades múltiples, tenemos también lo que es la discapacidad ortopédica, tenemos otros impedimentos de salud, la discapacidad específica de aprendizaje, el deterioro del habla o del lenguaje. También tenemos lo que es lesión cerebral traumática y tenemos lo que es la discapacidad visual, que también está incluida ahí la ceguera. Ahora, es bien importante que ustedes sepan que según la IDEA, un niño no puede ser identificado como un niño con una discapacidad, principalmente porque habla un idioma distinto del inglés y no habla ni comprende bien el inglés, ¿ok? Para poder estar clasificado como una discapacidad, necesita una prueba formal, una evaluación por un terapista físico. Y es posible que tampoco se identifique que un niño tiene una discapacidad simplemente porque no ha recibido suficiente instrucción adecuada en matemáticas o lectura. ¿Okay? Sí hay una ley de educación para, ¿verdad?, con un individuo de discapacidad, pero necesita una evaluación formal profesional, en donde certifique que el niño tiene cierto tipo de discapacidad. Ok, para niños y jóvenes de 3 a 21 años, la educación especial y los servicios relacionados se brindan a través del sistema de escuelas públicas. Una forma de conocer estos servicios es llamando a su escuela pública local, en donde ellos le puedan proveer más información sobre las políticas de educación especial que hay en su área, o si no, pues ellos lo envían a una oficina, ¿verdad?, del distrito del condado, donde puedan obtener más información. Y también pueden comunicarse con el Centro de Información y Capacitación para Padres de su estado para obtener más información. Aquí se encuentra el enlace. Y también si usted es un padre que cree que su niño, ¿verdad?, pueda necesitar educación especial o otros servicios relacionados, pues aquí también se encuentra el enlace donde pueden obtener más información sobre eso. Ok, ahora voy a hablar sobre el programa de educación individualizada. Este programa de educación individualizada está desarrollado para un niño que está determinado a tener necesidades especiales, ¿ok? Y esto se hace a través de unas reuniones anuales en donde ellos se reúnen y puedan entonces discutir un poquito más sobre las metas para entonces poder proveer un mejor servicio al niño. Y se hacen también evaluaciones trimestrales. Ahora, esto es todo un equipo que se reúne y ese equipo se compone de los padres, de los maestros, de los representantes del Departamento de Educación y los miembros del equipo de terapia. Vamos a hablar sobre fisioterapia escolar, donde el objetivo de un fisioterapeuta escolar es que son específicos de trabajar para brindar apoyo, equipo, intervención o consulta para promover una participación óptima para lograr las metas académicas del niño. También está los fisioterapéuticos médicos que se centran más en lo que son los desafíos del cuerpo, las estructuras, el ratio del movimiento, la curación de todo el tejido. Sin embargo, si hay problemas médicos que impiden la participación total, entonces se puede recomendar fisioterapia en la escuela. Ok, ahora vamos a hablar un poquito sobre las evidencias basadas en la práctica y terapia física pediátrica. Ok, la evidencia basada en la práctica es la integración de esos resultados que se han realizado, que se han obtenido de las investigaciones y la experiencia clínica y todos los valores para poder proveer los mejores servicios para su niño, ¿verdad? Obtener las mejores evaluaciones, las mejores intervenciones. Y los fisioterapeutas y asistentes pediátricos pues utilizan la evidencia basada en la práctica para poder colaborar con la familia, los proveedores de atención médica y los educadores para brindar las mejores prácticas. Ok, la práctica basada en la evidencia respalda el uso de intervenciones terapéuticas tales como actividades del desarrollo, fortalecimiento, movimiento y movilidad, gestión del tono, que viene siendo el tono muscular, aprendizaje motor, imaginación, recreación, juego y ocio. Tenemos también las adaptaciones de cuidados y rutinas diarias, diseño, fabricación y montaje de equipo, órtesis y prótesis, cómo ponerlo, cómo quitarlo, cuidado de quemaduras y heridas, que esto es más basado en hospitales, resistencia cardiopulmonar, programas de seguridad y prevención y uso de tecnología de asistencia. Ahora, ¿cuáles son las licencias para un fisioterapeuta y asistente? Pues mira, cada fisioterapeuta, cada estado tiene leyes que rigen la licencia y la práctica de la fisioterapia. Todos los fisioterapeutas y asistentes son graduados de una universidad acreditada. Hoy en día es un título de posgrado para fisioterapeuta y un título de asociado para asistente. Y los fisioterapeutas pediátricos pues tienen una formación especializada y desean trabajar con niños y familias. Aquí les dejo un enlace en donde pueden tener más recursos sobre esto. También tenemos el Centro Nacional de Salud, Actividad Física y Discapacidad, el cual fue fundado en 1999 y es un centro de recursos y prácticas de salud pública sobre promoción de la salud para todo tipo de personas con discapacidad. Okay, que aquí les dejo una información también para que puedan entrar ahí. Aquí tienen muchísimos recursos sobre diferentes tipos de deportes adaptados para los niños con discapacidad, el cual es sumamente beneficioso para que puedan mantener una vida activa. Aquí tenemos enlaces de soccer, de béisbol, aquí hay de todo un poco, ¿okay? En diferentes estados. También tenemos aquí, como pueden ver, diferentes tipos de tecnología de asistencia, ¿okay? Dependiendo de la necesidad de cada niño. Tenemos el famosísimo triciclo, el cual ha sido investigado durante estas últimas etapas. Ha sido investigado y han dicho que es sumamente beneficioso porque permite que los niños con limitaciones pues, puedan adaptarse a hacer prácticamente diferentes tipos de actividades al exterior con sus compañeros y todo. Y el triciclo también beneficia mucho con respecto al desarrollo del movimiento como tal. Y obviamente pues aumenta los niveles de actividad física, de cardiorrespiratorio, cardiocircular, aumentando la circulación y provee muchísimos beneficios para los niños. Bueno, y si tienen algunas preguntas, pues está aquí con nosotros nuestra terapista física pediátrica que puede ayudarnos con respecto a responder las preguntas que ustedes tengan. Muchas gracias.
Muchísimas gracias, señorita Liliana Romano. Soy Ginette Canero, la moderadora, y muchísimas gracias, doctora Mensa. No veo preguntas en el chat, pero le doy las gracias a todos. I don't see any questions in the chat, but I just wanted to thank you, Dr. Mensa and Dr. Liliana Romeo, for everything.
Gracias a ustedes por la participación, adiós por la oportunidad de estar aquí presente. Para mí es un honor poder llevar toda esta información en español. So thank you so much for the opportunity to be here. For me, it's like an honor to bring all this information in Spanish.
It was amazing. Thank you so much. Gracias.
Thank you.
Thank you. So we're going to wrap up. And if you have
Ya
any
terminamos.
yep, and if you have any questions,
Thank you so much, team. It was wonderful.
Thank you for
Thank
joining
you
us.
for joining
everyone.
us.
Gracias.
Thank you. Ciao. Bye.
Bye.
Gracias. Mucho.